David Mannino. Dr. Mannino is a Philadelphia native who graduated from Penn State and Jefferson Medical College before completing his medical residency and pulmonary fellowship. He worked at the Center for Disease Control and Prevention, where he helped to launch the National Asthma Program, and he worked on the epidemiology of COPD. In 2004, he retired from the U.S. Public Health Service and started his academic career at the University of Kentucky in Lexington, where he was part of the International Burden of Lung Disease team. In 2004, he became one of the original founders of the COPD Foundation. Following a 3-year stint as a U.S. medical expert at GlaxoSmithKline with a focus on COPD, he returned to the COPD Foundation as a medical director in 2020, and he served the foundation in multiple roles, including chair of the Medical and Scientific Advisory Committee, the chief scientific officer, and as associate editor of the Chronic Obstructive Pulmonary Diseases Journal of the COPD Foundation. Welcome, Dr. Mannino. I'd like to start with a question that shows how little I know about this subject. I hear two different words being used among patients, vaccination and immunization. Can you explain the differences between them?
Sure. And again, and thank you for the introduction, John. One thing that stands out with with an introduction is that if you haven't figured it out, I'm pretty old. So
you're not old.
I'm old. I've been around a long, long time, and have lots of grandchildren to demonstrate that. But yeah, and that was and we had a couple of sort of pre-questions, and for me, I had always sort of had viewed the term vaccine, vaccination, immunization to be similar, because basically a vaccine or a vaccination is the ability to get your body's immune system to respond to a therapy, or to respond basically to a shot, and immunization is the process of developing that immunity. Now, in recent years, there have been some people who have tried to make a distinction about that. For example, and there are some folks who carry, particularly, and we saw this in response to COVID, who describe themselves as being immunized if, in fact, they had for example, a COVID infection, but never received a vaccination shot. And they would say, well, I'm immunized because I, in fact, had a COVID infection and now have had an immune response to that. So that counts as immunization in the absence of vaccination. So if there is a distinction, it is that. But with that, it's although I don't have a slide on this, it might be worthwhile reviewing actually the history of vaccination, and that it sort of relates back to the history of smallpox. That smallpox back in the 1800s was a deadly disease, and one of the I think it was Dr. Jenner, who, while examining patients, found that that he had some patients who did not get smallpox, and in sort of interviewing these folks, he found that these were basically women who worked with cows, and in further interviewing them, he had found that they had been infected earlier in life with cowpox. And so Dr. Jenner then sort of surmised that being infected with cowpox actually prevented a person or decreased the likelihood that they would get smallpox when exposed. So actually the term vaccination is derived, I think, from the Latin term vaccina, which is cow. So the original origins of vaccinations started around smallpox, and since then, we have developed vaccinations for a number of different things. So with that, we can go on to the next slide. That was a free history lesson. And when I was asked to prepare this by Linda Walsh last month, I sort of jumped into literature and say, well, what do we have in the bronchiectasis and NTM literature about vaccination? And the answer is almost nothing. Which is not terribly surprising, but in general, bronchiectasis and the NTM community, is grouped with other people with chronic lung disease, and we know, for example, that other patients with chronic lung diseases are higher risk from vaccine preventable diseases because of both a combination of the respiratory system having decreased ability to fight infections. And another sort of free lesson here is other terms you might hear along the way is the innate immune system and the adaptive immune system. The innate immune system is basically everything in our body that prevents us from getting an infection to any type of organism, and no matter what it is. So for example, skin is part of your innate immune system. People who lose skin, for example, because of burns, are much more likely to get skin infections. So that's and those are likely to kill them. Within the lungs, the innate immune system includes things such as the cough response, or the production of mucus that actually provides a protection against all manner of viruses and bacteria that we're exposed to in a very non-specific way. And this is contrasted from the adaptive immune system. And the adaptive immune system is what happens when a human is exposed to a certain particle, virus, for example, or bacteria, that they then develop a immune response to prevent them from getting it a second time. And what vaccinations do is take advantage of the adaptive immune system, because without getting too technical, what happens is that your body recognizes a viral particle or a bacteria as foreign, and then develops immunity to that by developing antibodies to that specific particle, or and typically it's some sort of something related to the bacterium, typically a protein or a coating on the bacteria that the body is then responding to. And then the next time, and then this basically goes quiet and goes into a sort of a storage system. And the next time you're exposed to that, and the body can quickly sort of develop, ramp up and develop antibodies and fight that infection off the next time around. So in essence, what happens with vaccinations is that it's a way of sort of prepping the body by taking advantage of the adaptive immune system to respond to these infections the next time one is exposed. So with that, we'll sort of move on to, and this is sort of a general overview. Then I'll be going to some specifics in later slides. That this looks at the general guidance for vaccinations in people with chronic lung disease. And COVID-19, of course, we can just stay on that slide, has gone, you can go back the slide, thanks. It has now gone from pandemic to what's considered endemic, which means that it's going to be circulating the background each and every year, sort of like influenza. So we expect that there are going to be annual updates for COVID vaccinations. Influenza circulates seasonally, and I have an additional slide on that. Pneumococcal pneumonia is the most common type of bacterial pneumonia caused by Streptococcus pneumoniae, and with lots of different strains. And so this is another vaccine preventable infection. And it's important to realize that when we talk about vaccine preventable, that vaccines do not work 100%. And when I talk to patients, probably if I had a nickel for every time I heard, well, every time I get a flu shot, I get the flu, and that's and I would sort of pay my salary for a year. And the way vaccines work, that actually doesn't really happen. Although certainly people can get there are various side effects of any sort of vaccination. And as I explained when I talk about any sort of medical therapy, there's always a trade-off. There is nothing that is risk-free. And there's certainly, when we talk to patients, there are some patients, because of either prior complications or because of they have a history of Guillain-Barré or other things, that they probably should not get vaccinated, but that's a very small proportion of patients. RSV, which is a relatively new vaccine, respiratory syncytial viruses, is relatively new, and this is a vaccine that that there's that certainly it prevents an important disease that I'll be talking about, but there are it's one of these ones where CDC's recommendation that the patients sort of talk to their physicians and have a discussion, because if you're in a very low risk group, that may be one that you don't always need. Tdap is tetanus, diphtheria, pertussis, which is whooping cough, and that's something that we give to kids, but give boosters periodically in adulthood. And then zoster is preventing against shingles. So if we go on to the next slide. So this is what and I just sort of pulled this off the CDC website. And this is the current COVID vaccine recommendations. That basically, if you've been previously vaccinated, you should get the update, and there's a current update that's out there now, and I think we're expecting another one in the fall. And again, sort of like the timing of that, and I assume that almost everybody on here has probably been previously vaccinated. If in fact you've never been vaccinated, the recommendation in an adult age group is to get a dose of either the Moderna or the Pfizer BioNTech vaccine. Next slide. Influenza. The influenza vaccine what's included in the vaccine changes every year. Quadrivalent means that there are 4 different types of strains in there, and the way this works is that it's a bit of a guessing game from CDC and World Health Organization, that basically based on surveillance data and in general, most of the influenza strains seem to originate in chickens in China or in populations in China, and then sort of work their way to the rest of the world. So with surveillance data, World Health Organization, CDC, and other health organizations pick out what they feel will be the most likely strains, and typically it's either 3 or 4. So you might see the term trivalent, and so this was from last year. We have not yet seen a 24-25 vaccine recommendation yet, but I'm sure all the companies that develop these are working on them, and we'll have something later this year. Typically, and we start, and I know our clinic doesn't even get the flu vaccines until October or November, and that's and we typically then start administering them then. But the difference here is that in older populations, they recommend a higher dose vaccine, which is basically a double dose, as opposed to what's seen in younger population. I went in and looked to see if there was guidance as to whether people with respiratory disease should get a higher dose, regardless of their age, and I could not find anything specific that specifically answered that. So again, this might be something to chat with your doctor about. Next slide. On to the pneumococcal vaccine recommendations. And this is rather confusing in that there are two different major classes of pneumococcal vaccinations. Prior to maybe 6 or 7 years ago, and the only vaccination was something called Pneumovax, which is also it's listed here as a PPSV, or pneumococcal polysaccharide, vaccine, and this is a vaccine. And what is different about the bacteria that causes pneumococcal pneumonia is that it has this sort of capsule around it. So it's an encapsulated vaccine. And the pneumococcal vaccines were actually developed to target that capsule. And in many ways, they are, and the pneumococcal, or the old Pneumovax vaccines are somewhat less effective than the newer vaccines that are called conjugate vaccines, or PCV, that actually target specific strains based on and the more traditional development of vaccines, where it's actually targeting proteins within the pneumococcal bacteria. So you might have also heard the term Prevnar, Prevnar 13 being the first of these. There's now a Prevnar 20, and just to be completely confusing, there's a Prevnar 23 that will be coming out probably another year or two. And there's also a PCV 15 that goes by a different name, but it's made by a different company, so it's not Prevnar. But basically, so where this gets confusing is if you had a prior vaccination with a pneumococcal vaccine, because of crossover and how the immune response develops, and you should wait a year to get either the Prevnar the Prevnar 20 vaccine, or you can get the PCV 15. If you had previously had a Prevnar 13, and it's been more than a year, you can get either the Prevnar 20, which now includes additional strains, or you can get the Pneumovax. And this is recommendation for people under the age of 64 who have chronic health conditions, including chronic lung disease, including COPD, and I would add bronchiectasis to that. Next slide. If you're over the age of 65, the top part sort of looks similar to that. That if you previously had the Pneumovax and it's been more than a year, you can get the the Prevnar, probably Prevnar 20 is what would be recommended. If you previously had Prevnar 13 and it's been a year, you can either get the Prevnar 20, or the Pneumovax. And then where it gets sort of interesting, if it's been more than 5 years and you previously had both Prevnar 13 plus the Pneumovax, it might be worthwhile getting a reboot or re-immunized, with the Pneumovax or with the new Prevnar 20. And then finally, if you've had both of those after age 65, that's where you talk to your doctor. And I think and the discussion might end up similar to where you were before. And it sort of depends on your risk group. I'm over the age of 65. I've had my the Prevnar vaccination. I have not yet had Pneumovax. I may get that at some point, but since I'm otherwise healthy, it's less critical for me. Next slide. RSV. This is another one that's complicated, and this is for respiratory syncytial virus. Recommendations for children and pregnant folks is listed above it, and this is sort of highly linked to time of year, whereas people with chronic respiratory conditions who are felt to be at increased risk can get it year round. However, maximized effect is thought to be had by offering late summer or early fall. So we're sort of getting to that time frame now. Next slide. Tetanus, diphtheria, pertussis, or DTaP. And as if you've had kids or grandkids, and this is sort of a routine part of what happens with childhood vaccinations. Once you get into adulthood, the recommendation is every 10 years. And we still have pertussis that goes around, and we call pertussis the cough that lasts 100 days. And certainly it's something that we continue to see in adult populations. So next slide. And then finally, shingles vaccine and the new the 2-dose Shingrix vaccine is most experts will say, and this was much more effective than the prior single dose vaccine. I think it's we're talking about effectiveness it's in the I want to say 85 to 95% range, whereas the prior one was less than that. And this was probably the most painful vaccination I had. And my arm was sore for several days, and I've heard other people have that same comment. So, and I think that's an indication that the vaccination is actually working, that it's doing what it's supposed to. And it's supposed to be inducing an immune response. So, with that, next slide. So, is there anything sort of specific in the world of bronchiectasis? Because and in the NTM world, that that there are that the various mycobacterium responsible for NTM infections, are sort of cousins of the tuberculosis mycobacterium, and in some parts of the world, vaccinations against BCG, which is a sort of bacterial cousin to tuberculosis mycobacterium, and that sort of induces an immune response. And there has been down the bottom one clinical trial of this in patients with bronchiectasis that was completed late last year. I have not seen any results yet, and it was sort of looking at some feasibility of whether one might be able to sort of take advantage of the immune system to help people that have NTM, and currently, and there are vaccinations against M. avium, which is one of the more common NTM mycobacterium that's being evaluated in animal models. BCG, which I mentioned previously, is being evaluated in some animal models of Mycobacterium cansensi, which is another. It's not the most common, but it does occur in NTM infections. And the thought is that BCG may induce some sort of cross-protective immunity. And then in addition, there are other animals that are looking at some vaccinations in animal models of avian. So, stay tuned that there may be some vaccinations that come into play very specific to NTM infections. But I think we're still several years away from that because they're still sort of working their way through animal models and have to work their way into human models. And I just I look for U.S. Trials to not look internationally, but there may be things going on internationally too. And I believe that was my last slide. So with that, I guess we can.
Yes, thank you, Dr.
Questions.
That was an excellent, comprehensive presentation, and I'm really excited to hear more about the vaccinations in the pipeline for MAC and the